collaboration with Laerdal Medical. Today's webinar is titled Bridging Disciplines, Innovative Approaches to Interprofessional Education, presented by Dr. Joanne Piccininni. We're also joined by Tracy Mulcahy and Bridget Wynn from Laerdal. I'm going to pass it over now to Tracy for the introduction. Thank you all for being here with us today.
Thank you, Rio. Welcome, everyone. I love that I was going to suggest everyone say hello, tell us where you're from, and everyone's kind of taking the lead. I see some of my friends from New Jersey, so Joanne and I will feel quite welcome. So my name is Tracy Mulcahy. I am the product marketing manager for our medical emergency and trauma portfolio. I am joined by my colleague, Bridget Wynn. Bridget, you want to introduce yourself?
Yeah, hi everyone. I am located in Chicago, and I'm the Associate Product Marketing Manager for the resuscitation product line, as well as the spinal and airway products. So a lot of those products are relevant in EMS when it comes to spinal and airway medical devices, as well as our resuscitation little mannequins. Excited to have you guys here today.
Yeah, so in a moment, I am going to introduce Dr. Piccininni. I'm going to start a slide deck so that we stay on track. Please, everyone, continue to chat and ask questions. Bridget will be monitoring the chat while Joanne and I will be doing the presentation. So we do have a section at the end to answer live any questions. However, please don't hesitate if something comes to mind to please put it in the chat or the Q&A. Okay, so in the short term, let me share my screen. Okay, can everyone see my screen?
Yeah.
Not yet.
Not yet. Okay, hold on. Let's try that again.
Oh, perfect.
There we go.
There we go. We got it?
Mm-hmm.
Okay. So again, I am Tracy Mulcahy from Laerdal Medical. We are here to elevate your impact, which and hence aligns with our mission of helping save lives. So again, we are here as Laerdal working with NAMSI, and our topic today is Bridging Disciplines, Innovative Approaches to Interprofessional Education. And so I have had the pleasure to work with Dr. Joanne Piccininni for the last 10 years that I've been at Laerdal. And we're going to talk a little bit more about her background. But first, for those that don't know who Laerdal Medical is, we have an illustrious history of being a family-owned company, which was started by our founder, Osmond Laerdal. And kind of the process, if you don't know the story, they had a near drowning of his son, Tor Laerdal, who is now our president of Laerdal Medical, and got involved with the pioneers for what we know today as cardiopulmonary resuscitation, or CPR. However, in the 1940s, we started as a toy company. But what you really need to know about Laerdal is that our mission of helping save lives drives everything that we do. And we achieve this through the advancement of resuscitation, patient safety, quality of healthcare, and saving lives at birth in low resource settings. One of the things I wanted to bring to your attention in the top right is we have a 1 Million Lives podcast. It's awesome. It's amazing. We speak to lots of leaders in the simulation community, and I implore you to check it out. So without further ado, I want to introduce Joanne Piccininni. She is the Paramedic Science Program Director and Assistant Professor at Bergen Community College. She began her EMS career in 1992 and currently works as a paramedic for the Valley Hospital EMS. Joanne graduated from the University of St. Augustine for Health Sciences and was awarded a Doctor of Education degree in 2023. Congratulations, Joanne. I know that was a big accomplishment for you. She has presented at conferences nationally, state, and locally, and has helped author various EMS education courses and programs. She is an active member of NAMSI, NAEMT, and NAEMSP. Joanne, I'm going to let Joanne speak more, but she is just, she's an educator. She's a thinker. She wants to advance professional EMS and paramedicine education, and talk about how she coordinates with interprofessional education. So without further ado, I will pass it to Joanne.
Good afternoon, everybody, or good morning, depending on where you are in the U.S. today. It's afternoon here for me in New York State. I work in New Jersey as a paramedic and an educator, but live up here in New York, about an hour and a half outside New York City. It's a pleasure to be able to have the opportunity to speak to everyone today about a topic that's super important to me, which is EMS education. Thank you to Tracy and Bridget from Laerdal and Rio and team from NAMSI for inviting me to present today on a topic that is near and dear to my heart, and I continue to try and progress in this area. Having the experiences I've had in EMS education over the last couple of decades, I guess that ages me a little bit, has enabled me to grow and progress in this profession. I like the direction that we're heading right now in EMS education, and I hope that I can contribute to that, the success of that forward progression. I think it enables me to see things from different perspectives and develop my overall goals, which help me to help people succeed. That's what I tell my students. My goal is to help them to succeed, excuse me. And I think it's always worthwhile for us to keep our eyes and ears open as to better ways of doing things, how to do them better, someone having a great idea that you can latch onto. That's how I've gotten some of my inspiration over the years in EMS education. And I'm really happy and pleased to be able to share some of that with everyone today. So thank you so much for being here and taking time out of your busy days in your careers. So here's my list of objectives. I'm not going to bore anybody by reading from them directly, but I want to look at some of the different goals and importance of interprofessional education in healthcare is, in particular in EMS. Apply those principles of team-based learning. Talk about standardized patients and participants. And the main goal of talking to you today is, how can you do it? If I can inspire you with some ideas of what I've done in the past, I consider that a success for today. So I'm looking to try to I guess, motivate and inspire you to do some interprofessional education of your own. So the World Health Organization Framework for Action on Interprofessional Education and Collaborative Practice back in 2010 states that interprofessional education occurs when two or more professionals learn about, form, and with each other to enable effective collaboration and improve health outcomes. And that is, to me, really an all-encompassing perfect statement about interprofessional education. We do it, there's important reasons why we do. We want to reduce errors, improve those patient outcomes, see our patients get better and do no harm. And it prepares our participants and students for real world practice. Some different goals, developing that mutual respect across the continuum of different health professions, from EMS into the other areas in the hospital or even outside the hospital. Outcomes-based goals are what we want to develop. We want these goals to be clearly articulated. We want them to be achievable, measurable. We want them to be competency-based, so they're at the appropriate level for our participants so that they can actually get something from the experience. For example, you may have a set of goals for the paramedic students that you may be teaching, or the providers that you educate. Another set for the other program you're integrating with, and putting, when you put together your interprofessional session, or have collaborative goals. What do we want to achieve for both of those groups, 2 or maybe even 3 different groups that you're working with? And many times these goals are very closely related and they overlap. So some of those benefits, I talked about improved patient outcomes. I just mentioned that a couple of minutes ago. Contributing to patient safety, making sure that we enhance our teamwork with our other health profession team members so we can reduce those errors, giving the participants a place to make those errors and make those mistakes so we can correct them, and moving forward, it's something that we can improve upon. Having enhanced teamwork and communication, right? Communication is everything in this business, making sure that we're speaking the same language. And if we're not, how can we come to a collaborative language that we can all use and we all understand? Reducing the conflicts between each other, right? So a lot of our conflicts come from not understanding what each other does. And interprofessional education can help to contribute towards that collaborative language. Increase professional satisfaction. People coming out of these sessions thinking, wow, that was really supportive. You know, I don't feel intimidated by working with the physicians because I'm a new provider or I'm a student. I actually understand what they're talking about and can have a clinical or professional conversation with them when we're both on the same page. And as a result of that, having higher job satisfaction and being happy with what we're doing with our careers. So when we talk about core competencies development, we're talking about a few things here. So when we're developing our interprofessional education, we want to use one or more of these particular themes. You may call them something different. These are just some common terms that we can use for these themes. We can consider these as an outcome when designing our interprofessional activities. So we can decide that we want to focus on ethical practice. Ethical practice involves an integrity and respect in relationships, right, between the team members. How we can hold our team members responsible and in an ethical light, keep them at the highest level of integrity, giving them an opportunity to practice how to integrate and make complex ethical decisions about a patient as a team, making sure that everyone has a say. Roles and responsibilities. Understanding and respecting the roles and responsibilities. So no single health professional or health profession is capable of meeting all the patient's needs, right? We see that in our healthcare systems. Gone are the days of having one doctor that treats you for everything that may, be an issue for you in the medical sense. Integrating EMS in that is another step towards that collaboration. Conflict and tension between individuals can arise from those people that step on each other's toes, right? The lines are blurred as to who does what. But if we can practice and collaborate, develop our teamwork, we can achieve our higher patient goals, our better patient outcomes by focusing on those roles and responsibilities. Who's responsible for what in a situation? Our interprofessional communication. So communication, as I said before, is the center of it all. Practicing that effective information exchange, speaking the same language. Poor communications linked to poor patient outcomes, potential harm, that missed message, that misinterpreted message, right? When we practice our rotations, in mega code situations, we do it in education. Why not branch out and work with our other healthcare partners to treat those patients and make sure we're speaking the same language? The communication exists on individual levels, on group levels, and it could be formal in the form of a meeting or patient records. It could be informal in emails or just passing comments. Some of you have probably heard of SBAR or may use them in the organization that you work for in the high reliability organizations. And SBAR is that clinical handover design that uses situation. S is situation, B is background, A is assessment, and R is recommendations. So we can come up with it's essentially a plan. And our different protocols to assist in effective workplace communication. So we can use SBAR as one of those tools to ensure proper communication. As a really simplistic example of that is that EMS turnover of a patient to the emergency department, right? It's what we do every day that we're in the clinical environment. We're turning over patients, making sure that that continuity of care is intact and that patient gets the best care possible because we communicated well and everybody got the same message and we're all on the same page. And then we have collaboration and teamwork. We can work on this in our interprofessional education. How can we effectively collaborate in teams? It's a central component of interprofessional education. Without this, we can't effectively function. Then we're basically operating in a silo. You could have paramedics in one silo, nurses in another silo, even down to our diagnostic imaging partners working in a silo, our physicians. We want to make sure that we can collaborate and have good teamwork. regardless of what activity that we're taking place in caring for that patient. We know that that improves patient care and safety. Next slide. So just a little bit about simulation, right? So what is simulation-based education? And very, very simply, it's realistic and reasonable scenarios to practice skills. And I use that term reasonable. You'll hear me talk about reasonable and realistic a few times in the next few minutes. We want to make sure that we keep to our realistic expectations. There's a couple of different types of simulation. We have our high fidelity simulations. This is when the healthcare education methodology involves sophisticated mannequins, right? So those mannequins that blink and breathe and their chest moves, and we can situate our facilitator in another room and we can actually speak through a speaker. They have lung sounds, they have pulses, etc. High fidelity comes in the form of virtual reality, which is a trend that's come upon us the last couple of years. Or we can use simulated patient actors in a realistic patient environment. It's another form of high fidelity simulation. When we're talking about low fidelity simulation, very basic again, in basic terms, it's less realistic than high fidelity, right? So it's going to lack those aspects of realism, those different components of realism than a high fidelity simulation may. So for example, you're using a task trainer that you're teaching medics how to start an IV, or another healthcare provider how to start an IV. So that task trainer can give them that tactile feeling of inserting an IV into a realistic task trainer. But the student or the participant doesn't have that experience of witnessing the patient's reaction to pain, or giving them therapeutic communication, explaining and getting that reaction, that recognition of, yes, the IV is going to hurt and how much it's going to hurt, etc. Standardized participants and patients can be used in simulation. Those participants or patients can take that simulation one step further, bringing that element of therapeutic communication or even clinical judgment for your participants. Getting that reaction from a real live person can enhance the simulation. There's different benefits to doing any of these, and you can use a vast combination of any of these. You don't have to use just one type of simulation. It can be a mix of high, low, and using a standardized patient. And we know one of the benefits to doing simulation is giving the participants that safe practice environment. We give them immediate feedback, where it provides them with psychological safety. They can talk about how they can speak up. They can speak up with their team members. They can speak up without fear of being dismissed or being rejected or embarrassed or ridiculed, right? So they can admit and be vulnerable and say, I don't know, or okay, I know I did that wrong. How do I do it the right way? It's a place for them to make mistakes or errors, and so that we can move forward and fix those and mitigate any problems with live patients. So case-based learning. What we know case-based learning to be is it's learning through those detailed scenarios that we develop. It's going to enhance that critical thinking of having that realistic scenario, real world scenario. Make sure you have your objectives are clear, and you share those with your students or participants before you start, so they know what you expect. Ensure that they're realistic. A vast majority of the simulations and scenarios that I write are based on my own or my program faculty's patient experiences in the field. We all share those. Oh my gosh, I had this patient and this was the situation. And a lot of what we draw from to write our scenarios is based on that. They're real life patients. They're not unrealistic situations. So we're drawing from the experiences we have, how we treated those patients, how those patients reacted to our treatments. We want to make sure that the way we write these scenarios are based on our learners' capabilities. We don't want to exceed those capabilities, right? It goes without saying. We don't want to, write a high level skill scenario if the students aren't taught how to do those skills or think in that manner. So team-based learning. So team-based learning is what is the center of interprofessional education for me. It involves those multiple disciplines. They come together for care to care for the patients. Health profession students have traditionally been educated within the confines or those silos of the discipline-specific curriculum, right? So this allows us to branch out to give them that exposure to communicating with other health professions, working with other disciplines if you're in a hospital situation or out in the field and you're not in an academic setting. There's a few advantages to this. It's effective in teaching that team performance concept to the multidisciplinary teams. The disciplines can come together, participate in interprofessional collaborative patient-centered care, again, in that safe environment that provides its psychological safety, where, we want to practice before we actually implement what we're doing on live patients. So talking a little bit about role playing and standardized patients, I like using standardized patients. I've branched out a little bit more with using the standardized participants or patients. I utilize my faculty to achieve that, acting out or role playing the scenario. Just the strict definition of role playing is learners are tasked with acting out those scenarios, right? So making sure they're trained in what we need to do, making sure that they know the objectives of what we want to succeed with and what we want to, how the scenario needs to go, what we want to, objectives we want to cover with our students. Using standardized patients or participants can promote consistent and realistic scenarios. All right, so it's much easier to help a student work on their interpersonal communications with someone who has a reaction back. They have facial expressions. They can speak back to them. They can react to the way, not just the words they're using, but the way they're speaking to the patient. So that can have a profound impact between, versus a mannequin that, yes, high fidelity mannequins, they're amazing pieces of machinery, but it's not going to necessarily 100% replace that therapeutic communication experience a student can have talking to a real live person. So with everything we latch on to and we do, we're going to have some challenges. And with challenges, we need to come up with solutions. And sometimes it comes along with maybe not succeeding the first time, but realizing what the challenges are, embracing them, and improving upon what we're doing. So some of those common challenges we might have, scheduling conflicts, right? Depending on the education environment that you're in. I'm in a community college. We have a total of 10 health professions programs, everywhere from nursing to respiratory therapy to medical office assistant and dental hygiene, et cetera. Sometimes getting that schedule to jive and to line up with what objectives or where your students are in the curriculum can definitely be a challenge. Some people are resistant to change. You're going to figure out real quick who you can partner with and who maybe is just not interested in partnering, and they've always done it this way. We hear that in EMS sometimes. I don't hear as much as I used to, thankfully, but sometimes that's the case. Resource limitations, right? I consider myself pretty fortunate. I don't get everything I want, but I have resources that are available to me on our campus, on our campuses, I should say. Training our facilitators, right? So you might ask me, where'd you learn how to do this, Joanne? Well, I learned by watching, right? I learned by observing. I learned by listening. I learned by just kind of making a mistake, admitting it didn't work, and okay, let's figure it out. So training your facilitators can definitely be a challenge, and figuring out how to get everybody on the same page. Most learn how to conduct them just by learning, by watching. I've had people come in that have participated and said, when are we doing this again? Because I learned so much, I want to implement something else, or I have an idea. So we can turn, a common challenge into a positive. So those strategies, right? So how can we come up with solutions to doing an interprofessional education, right? We know everything has to kind of come together in the perfect storm, right? So flexible scheduling, just need to be flexible. making sure that everybody can be accommodated, having that administrative support. Again, my boss, my dean, is one of her biggest focuses is in interprofessional education. So kind of natural for us to do a lot of it between the disciplines, between paramedic and other disciplines, between other health professions disciplines in our college and the others. You know, we're surrounded by like-minded people. That's a strategy, having the same people on the same page. Who, you know, think about it. Who would you want to collaborate with? Who do you get along with that you have a common vision for healthcare in general? Or if it's specifically for EMS, who are those people? Who are those players? Are you involved in a hospital system? Are you in public safety, in the public safety realm? Who in your world do you feel will be an ally for you? Open up the conversation. I've gone to people and said, hey, you know what? I want to collaborate with you. What can we do? And they have a whole list of things that I never even thought of. You know, I learn a lot myself. So, you know, not only giving your ideas, but you know, keep an open mind and listen to the others in your field. So how can I do this? You're probably like, wow, how can I do this? That's I said to Tracy, I said, that is my goal here. Like, how can I teach people how to do this? And you don't need to start off big. It can be small. It doesn't have to be anything crazy. All right. You know, one of the small things we've been doing for many, many years is our incoming students who are EMTs and our outgoing students, the ones that are graduating in a few months, they're essentially a few months away from being paramedics. We integrate them and have them collaborate and do an interprofessional education. Right, so they work together. The new students are the EMTs treating the patient initially, and the paramedic students that are on their graduation path are the paramedic or the ALS participants, the ALS providers. You know, like I said, I'm very lucky to have like-minded people surrounding me. We have a dental hygiene program at our school that's very robust, and we figured out a way to work together, managing medical emergencies in a dental office, handing off that patient care. And we actually last year we've always had dental hygiene and paramedic work together. And this past session last year, we integrated respiratory therapy. So dental hygiene had the patient in the dental chair. They activated 911. The paramedic students responded, treated the patient, and then we transported to our emergency department where the respiratory therapy students were waiting for handoff, and they helped to treat the patient. So again, that's just an example for you of how we've just taken another step forward, and it's a baby step. It wasn't anything major. It was a baby step. Surgical technology, right? Our students need to go through the operating room. Who remembers going through the operating room and how intimidating it was, right? They didn't have this in paramedic school many, many years ago when I was there. I didn't know who anybody was. You know, the surgical technology students are working with the paramedic students to teach them about the sterile field and where to stand and who everybody is. And the paramedic students took the advantage of, you know, teaching them about airway management. Medical office assistant, we did a program with them, collaborating with them. I got this idea from an EMS partner of mine about looking at autism spectrum disorder. We did, and I'll talk a little bit more about that in detail on a couple of slides. You could use it for new student or employee orientation, integrating, again, EMTs and paramedics working together to take care of a patient or achieve a goal. Keep it realistic, patient handoff, team collaboration, and your expectations. Keep it all realistic. It could sort of something really small, integrating and getting people on the same page in your department, your new EMTs, your new paramedics coming and working together and collaborating on patient care. So we got to do the work, right? So we got to recruit people to work with us. Again, like-minded people, those colleagues that have common goals and objectives. Keep your ears open, listen, keep an open mind. Students are your captive audience, right? So I have a captive audience. My students can't tell me no, they don't want to participate. You know, your students or your employees, recruit them to participate. Determine your common thread. So for example, that common thread between dental hygiene and EMS is that medical emergency in the dental clinic, right? Running through. collaborating with the respiratory therapy students in the ER, taking patient care. If you're in the healthcare realm where you're working with employees, maybe it's okay, collaborating with the emergency department. How do we bring the patient into the emergency department? Who's going to receive the patient? What's the arrival process? Do you have a stroke protocol where you go straight to the CT or straight to a room? Who are the people that are going to be greeting you and taking report from the EMS team? Who is everybody in the emergency room that's going to be taking care of that patient all the way through? Making people more comfortable with their environment is definitely going to contribute to better patient outcomes. Designing. Okay, so designing that interprofessional education session. Decide what your general and discipline specific objectives are, right? So what are the core competencies you want to focus on? It could be one, it could be two, it could be three. Don't bite off more than you can chew, but keep them reasonable, okay? Especially starting off, even though I have a couple of years doing this, I still try not to be too grandiose in what my core competencies are. Sometimes it's one, sometimes it's just communication, right? Which we know is essential. Design your scenario to be clinically sound. It doesn't have to be what I call that category 5 what if twister situation, right? Like everything that can happen happened. Some people out there who have been around as long as I have and had to get tested on the mega code, right? The mega code was truly what we call mega code now is not the mega codes that we did 20, 30 years ago, right? It was, you saw every rhythm under the sun. And that was your exit to maybe being a paramedic and testing out and getting ready for National Registry. So it doesn't have to be anything close to that. It'd be something really simple. Make sure you collaborate, right? Collaborate your interprofessional partnerships. They're based on cooperation, that mutual respect, shared decision-making, coming up with just one idea and it blossoming into something, really great. Consider how your participants' roles fit together to accomplish your desired goals, how to treat the patient, what communication looks like, testing out a process before it goes live. I used the example of like a stroke code earlier. How does that look? Maybe we should practice it first, and sometimes things in our brain look really great until we kind of go through the motions of acting it out. And then we realize we have a couple of gaps to fill. So, we can collaborate and do that in an interprofessional education session. So designing your effective sessions, right? So design your interactive learning activities, ensure everyone has a role or a task. In some of our sessions, we have what I call active observers, and those active observers are gonna watch and they're gonna participate in the debrief. Okay, so everybody is involved in what's happening. Everybody's paying attention. Everybody is taking mental notes or written notes as to what they want to offer to the group as far as an improvement that can be done or something that they did that was really great. Your different topics, you can pick different topics. It can center on patient safety, ethical situations. We can focus on team dynamics, communication, and we can work on our interactions between the professions, truly understanding what the responsibilities of the surgical technologist is, can go a long way for a student who needs to rotate through the OR. Having those interactive activities, including those active observers, if you have the capability, if you're dealing with larger groups, dental hygiene has a very large program. Many of our sessions, we have them sit out in their lobby and we live stream from the area where we're conducting the sim. Those are the active observers. They're watching, they're taking notes, and they're going to participate in the debrief. Not everybody has to be in the room at the same time. You can stream it out to an area where everybody can sit and take it all in essentially and participate in the debrief and the improvement process. So here's our dental hygiene clinic. This is up at our main campus in Paramus. They have a really nice setup. They do see live patients, so it is true to what they do. And you could see there our paramedic students are interacting with one of our high fidelity mannequins, and our dental hygiene students, who are the first to have contact with the patient, have activated 911, and the paramedic students have responded, and they're working collaboratively to treat this patient. This session we've been doing, I think, as long as we've been a program, and we just are continually working on improving it, expanding it, little by little, baby steps for us. And the students really enjoy the day because they learn a lot about each other. I learn something about dental hygiene every time. I learn about how that's not for me. I'd rather be a paramedic, but I have a great respect for what they do, and it's an important job. And the paramedic students and dental hygiene students learn a lot about each other from this session. Just another view, you could see our paramedic students are interacting with our mannequin, treating our patient. And you can't see it, but the camera it's in that right-hand corner there, but our dental hygiene student is interacting and handing off the patient, essentially providing important information to them so they can treat the patient. This is another session that we do. This is our OR orientation and advanced airway session. So we have a very good friend to the program, a CRNA who has a history in EMS, who comes in and helps us with orienting the paramedic students to the operating room. Again, very intimidating place for paramedic students. The surgical technology students are there to help them to learn where should they stand, who everybody is, what not to touch. What a sterile field is, how to walk through the OR without, touching anything you aren't supposed to, who everybody is behind the masks, right? Everybody looks the same in an operating room, from doctors to nurses to the surgical technologists. So our objectives here are the surgical technology students share their knowledge of the sterile field, where to stand, how to walk, what their responsibilities are, understanding their job. Our CRNA helps with the orientation to, who the anesthesiologist is, how they interact with the patient and the rest of the team. And then next slide, Tracy. The paramedic students in return teach the surgical technology students what they do in the OR. It's airway management. They share what they've learned in airway management, advanced airway management knowledge and techniques. You can see they're using video laryngoscopy there. And they're teaching each other. We just let them go. Well, this isn't anything that we're keeping a short leash on. We're like, okay, let's teach them what you know, teach them what you've learned this week. And they have a great time, and they also make interpersonal connections with different people in health professions. So it really is a good day. Something new that we did last year was we worked with the Medical Office Assistant Program and our Office of Specialized Services to look at autism spectrum disorder. With the OSS department's help, they recruited essentially some of our alumni who are autism spectrum disorder diagnosed, and they provided a panel discussion. So they shared with the group how it feels to them to be in a medical office, how they were treated because their healthcare professional knew they were autistic, and how they felt they were treated differently. And some of them, expressed how sometimes they don't tell them because they're fearful of not being treated well or with respect. The students were educated with different tips on how to engage with individuals with autism spectrum disorder. The use of sarcasm, right? Everybody knows Sheldon from Big Bang. The use of sarcasm and how it doesn't always, they take things very literally. And, some of us have a way of speaking that could be sarcasm, where we can't use that kind of language with people that think very concretely. And those core competencies that we used were engagement and communication strategies and teamwork. So we worked together with the MOA students and our paramedic students. We finished our panel discussion and we broke up into small groups, and we did some simulations with our autism spectrum disorder alumni, actually acting as standardized patients. And a couple of them, when they were in school, they were actually theater students. So they did a really good job of, pretending they were sick essentially. And they responded just as they would in a regular medical office. And it was an excellent opportunity for the paramedic students and the MOA students to effectively operate together in, providing respectful patient care to those that they're treating. So we've done our autism's, our interprofessional education, we've done it. We want to know how it went, right? So there's some different methods we can do that. We do that in our debrief, right? So essentially we give our immediate feedback. We convene for a debrief using, utilizing our active observers, our participants, our faculty, right? Feedback, debriefing, what went well, what didn't, what could we have done better, etc. We can use surveys, right? So we can produce a short survey monkey or whatever, or Microsoft Forms or whatever you have. They're free. You don't really have to pay for most of them if they're short, to get feedback from the participants. And you can do a separate one for the faculty, how they thought it went. Is there any suggestions to make it better or things we want to do differently? Giving the participants the opportunity to put their thoughts down on paper, right? A reflection essay, right? That they can write out what they thought of the session and what they thought they got out of it. We can do we can utilize peer and instructor feedback. We can do a self-assessment. What we'll do is we'll share recordings. So the system that we use for audio video to record, we can share their snippet with them so they can learn from watching themselves. And of course, continuous improvement. Like I said earlier, we always want to improve and do things better. So how can we do that? We can regularly update our curriculum based on the feedback. It was the first time we did the autism spectrum disorder panel. It was essential for us to get feedback on that, to find out what we need to do if we need to do something differently. How the participants from the panel felt. Did they feel like their message went across? Did the students get the message they were trying to convey? And how can we just overall improve that interprofessional education session to achieve our objectives and goals? Did we achieve our objectives and goals? So the future, right? So I'm always looking to the future with my feet firmly in the present, right? I think most of you do that as well. There's lots of good stuff going on out there. There's all sorts of different emerging technologies. There's virtual reality, which uses computer modeling and simulation that allows people to interact with an artificial 3D or visual or other sensory environment. There's augmented reality when it combines that real and virtual imagery, and you can interact in real time, right? So using the goggles and maybe a simple task trainer mannequin, and then they put the goggles on, it looks like a real person laying in front of them that has facial expressions and can speak back to them, etc. Using artificial intelligence to produce patient encounters. We see those in different apps and stuff online that we've probably been using as educators as well, or students are using to hone their skills to prepare for the National Registry exam. There's virtual patients on there that can speak for themselves, answer questions, respond to therapies, and gives them that real-time feedback. You can get really crazy and talk about global collaboration, and that could be international. I mean, I don't have any aspirations of that just yet, but between different programs, between different education programs, academic programs, or different programs or departments that are within your geographic area, or if you have, we all network, with different people across the country. Maybe there's somebody in a different part of the country that you want to integrate with. Using technology for interprofessional education in different online platforms. So Zoom, WebEx, Teams, right? We used Zoom during our panel because we had a couple of panelists who actually were on Zoom on the screen who participated in the panel because they weren't able to be there in person. So we use that online platform to do that. All of this allows us for flexibility, that online collaboration. It's flexible, it's cost effective, and it gives you different diverse perspectives from maybe a different geographic area or a different program. Maybe you can't meet in person because of different geographies. So there's a lot in the future that we can look forward to. So just to summarize a bit of what I talked about, about the importance of interprofessional education. Why is it important, right? It helps those students and providers from different health professions learn and collaborate with each other, because the ultimate goal is improving patient outcomes, patient safety. We can learn from the errors and mistakes that we may make in the simulation. I mean, I've made mistakes and I know they resonate with me. It's like, I'm never going to do that again. Hopefully people have that experience and can make a positive out of it. Benefits being improving collaboration and teamwork amongst the different disciplines, understanding what each other does, so we could speak the same language and work together as a team and have that mutual respect that contributes to patient outcomes. It can contribute to improving communication, the patient safety, again, that collaboration. And then what is the future, right? Continuing that collaboration, branching out to different areas. It could be in healthcare, or I don't know, maybe something outside of healthcare that you have an idea that you want to integrate with it, something that's maybe not in healthcare, maybe it's out there in the realm of public safety. If you're healthcare healthcare system based, like the system that I work in, you want to integrate out into public safety and fire and police, et cetera. You can do it. You just gotta, put your idea out there and keep an open mind and listen. So there's my contact info. Please email me if you have any questions, anything you need help with. I'd be more than happy to share anything with you that I spoke about today. The only social platform I'm on probably the most is probably LinkedIn. So I included a QR code there for you if you want to connect with me, and we can have some conversations about anything we talked about today or beyond.
Thank you, Joanne. I wanted to open it up for questions now, but before I do, I just kind of want to reiterate, because again, I've been so lucky to be in New Jersey and work with Joanne over the last couple of years. So I kind of want to drive home one of the things that Joanne talked about, and we talk about this all the time, because there is a question that Bridget's going to get to, kind of what I call like the zebras, right? And, wanting to push students, not pre-briefing to make sure that the students understand, forcing them to clinically think. And I just kind of wanted to go back to that for a minute, and how we talk about the foundation of learning, right? If we can't communicate and we don't do a good assessment, what is, the zebra, the ultimate most difficult patient going to do for that student if we don't have, or that healthcare provider, if we don't have the foundation?
Right. It's a good point, Tracy. We need to have that foundation. And, we talk about learning from our mistakes, right? So I hope that there are things that I made mistakes in, that I've learned from, that I can convey to, my students, or in, outside of academia, outside of the paramedic program, to help that people succeed. And we have to have that base, because what's the ultimate goal? Patient safety, collaboration, teamwork, right? All good points, Tracy. Absolutely.
So Bridget, do you want to go through the couple questions that we have?
We got 5 questions submitted through the Q&A, and then I do think there was one in the chat that I'll get back to. Yep. The first one was from Stephen Alexander. His question is, assuming a positive result from implementing IPA, what physical layout technology improvement should be made within the EMS vehicle itself that would assist transferring the imparted learning into an enhanced result when transitioning the patient to a hospital venue?
So I think what he's asking is what we can do to improve that transition from the EMS vehicle into the ER, like an idea for that. Is that what it seems like, Bridget?
Yeah, I think it's asking for specific improvements that should be made within the EMS vehicle too.
So Joanne, do you want to talk specifically about kind of your program and how important it was when you developed the program at Bergen, how you guys have an ambulance, you have a cut ambulance in your sim center, you do physically bring that patient in for realism?
Right. So thanks, Tracy and Bridget. So yeah, so I think it's just a lot of it is immersing the students in that environment, right? Or your participants in that environment. So we have an ambulance that was reassembled inside of an old van ambulance that was assembled inside of our simulation space, our education space. And then we have a real rolling simulation ambulance. And what we'll do is we'll take the students from initial patient contact through assessment and treatment all the way up to into the ambulance. So where are they putting their equipment? So we work in New Jersey where we're a 3-tiered system, right? A multi-tiered system. So the EMTs are the first contact the patient has with healthcare, and then the paramedics respond in a separate vehicle and then interact with the patient and the EMTs. And I'm essentially going into someone else's house, right? So where am I going to put my tools to succeed? How do I need to set myself up for success so I can reach everything I need? I can be respectful to the patient and be at eye level and be in a position that I can properly treat them as well as keep myself safe. So I guess the answer to his question is setting people up so that they can do the job, right? So making sure things are accessible, making sure it's set up the way it works in the real situation. Being in administration before that, it wasn't about how the ambulance worked for me. If I was, we came up with a new protocol, it's about how it's going to work for the providers. So setting your environment up for success, because we do go into uncontrolled situations where we have to do that. We have to set ourselves up in a situation so we can best treat our patients and work collaboratively.
Stephen, make sure you tell us in the chat if that's the complete answer, if we need another part of that. But I definitely want to move on because we have a couple more questions.
And he can always email me separately as well. We can talk a little more.
Okay, the next one is from Bridget Weiss. I'm advocating locally in Maryland to do quarterly training on exited delirium patients due to any number of causes such as seizures, behavioral health emergencies, illicit drug, ETH overdoses, diabetic emergencies with police. Does your jurisdiction do any training like this? Thank you for this amazing webinar.
You're welcome. Thank you so much for being here. So the students, we do a module on agitated or excited delirium, whatever the terminology is that you're using in your geographic area. And we do have simulations that are built into the curriculum that we implement with the students in our academic area. But I haven't branched out yet, so that could be an idea that you just gave me. Because my wheels are always turning. But I haven't branched outside of the school yet. But we do some successful simulations using standardized participants to replicate that situation for the students.
All right, next question, Veronica Jastrova submitted this one. Her question is, are you planning while preparing scenarios if this will be more communicative and needed to use the actor or more technical and prefer mannequin?
I have to be very honest and say that we work by semester. So I'll say in the last couple of semesters, I've implemented the standardized participants and patients a bit more, because I've discovered that that's how our students do better in what they're doing. So in other words, for them to have a real live person to speak to, it makes it more natural, right? So talking to, no offense to Laerdal, but talking to a plastic mannequin is not the same as talking to a human, right? And having that human interaction. And the light bulb kind of went on over my head with a couple of students we've had recently, that it sounds like they're acting, like they feel like they're acting out the situation, and they sound almost sing-songy and unnatural. And then you put them in front of a standardized patient, and they're actually talking to them like you can hear the empathy and you can hear the therapeutic communication a lot better when they're actually talking to live people. So we've done more of a combination lately, and I'm fortunate enough to have faculty who are very into acting out as the standardized participants, the family member or the nursing home worker, et cetera, or the physician or whoever. And we've done a combination more recently. So that's worked out really well for us. So I encourage you guys to use a combination of what you have available to you.
Next question was submitted anonymously, but it kind of goes off of what you were just talking about. They asked, if we utilize role playing with standardized patients, then they only know how to manage those standardized patients. Wouldn't it be better to role play with weird or obscure patients in order to encourage critical thinking?
So does this person mean like a real person, like a real patient? Is that what it comes across as, Bridget?
Imagine maybe a real person just with
And I think this also goes back to like weird and obscure versus building the foundation, right? It all comes back to what our learning objectives. I mean, that's the way I'm reading it. I think it's twofold, Joanne, is like, do we want the bizarre, or do we need, again, a combination? It all goes in our learning objectives and the stacking of the skill, right? And the learning.
Yeah, I think you could do both. I think you want to make sure you stick to your objectives and don't make it that category 5 what if twister situation that is unmanageable and frustrates your learners or your students or your employees. You don't want to frustrate them, obviously. I think you do a combination of it. I think I probably we do some weird and obscure cases. We do implement that. But I rely more on that in their live patient time and their clinical hours and their field hours on the paramedic units. They're probably going to get that a lot more than I can actually replicate accurately in the simulation situation. We can only come so close, I think.
All right, the last question in the Q&A section is from Seamus Moore. His question is, in your experience, how do you balance the simulation moments where competency and assessment is the main goal versus the other moments where simulation training is just used for skills and practice, and the idea of assessment is a bad word for psychological safety of the learners?
Very good question. It is a very delicate balance, right? So I think we have to keep our eyes open to everything, and we have to look at the overall picture of what they're doing, right? So we're going to have our specific objectives and goals in our simulations, and we need to, the students aren't always going to achieve every single objective and every single goal 100% all of the time. And I tell them all the time, this is not a test, this is practice, even though they think every simulation is an assessment and a test. It's a really good question. I think we need to keep a balance. So what did they do well, and what do they need? What do they have gaps in? What do they need to improve on? And in our debrief, we let the students drive that. We let the students drive the conversation of how they did and what they think they could have done better, or what they did really well. And they're really good with critiquing, giving feedback to each other as well in that situation.
So real quick, last question on the piggyback of that, Joanne, because I think the debriefing process is a humongous piece. At Bergen, how did you come up with one particular model? And you talked about facilitation and making sure that everybody's kind of on the same page. Do you have one model that you all use and standardize?
Yeah, we let the students drive. We let the students drive the debrief. We want to know, some of the questions we ask is, what did you do well? The plus delta method, right? So what did you do well? What would you do again? What worked for you? That's probably the main one that we use, that all of our faculty are very well versed on. It's not about, giving just feedback. It's about hearing the students, because a lot of times what we have in our mind of what we want to make sure they pay attention to or draw their attention to, they're already coming out with it. And they after the first few weeks, they develop a relationship where they feel comfortable telling each other and giving each other debrief information to improve.
Yeah. So before we move on, because I know we're running out of time, I just wanted to make sure everybody goes into the chat. There were some really good ideas and feedback that some of the attendees put in. So please don't hesitate to keep chatting. Real quick, Bridget and I just wanted to bring to the front that another thing that Joanne talked about is what we talk about a lot at Laerdal, which is the circle of learning, right? That knowledge acquisition, skills, decision-making, simulation in teams, and then obviously actionable insights and overall healthcare improvement, that there's steps, right? There's a foundation, and then we build on to that learning experience. And we just wanted to remind you that, Laerdal has so many tools for you to provide and meet your learning objectives. And we just kind of listed a couple things here, things from CPR feedback devices to airway management to, high fidelity simulation. But really wanted to, again, just remind you about Laerdal and our 1 million lives mission of saving 1 more million lives every year to the year 2030. You can learn more about our commitment with our QR code. You will be getting a follow-up email so that you get a copy of the recording. Please share it. It will also be a reference on Laerdal's website for you. We cannot thank you enough for being here. And of course, for Dr. Piccininni, her insights are incredible. Please, I hope that you can take 1 or 2 things from this webinar and go out and get comfortable with being uncomfortable, right? I think what Joanne said is, get with like-minded people, get uncomfortable in the mission that we share together in helping save more lives. Thank you, everybody.
Thank you.